Well, hi everybody. Welcome to our, I guess I don't know that we can call it our bonus webinar anymore. We might have to come up with another name. I think it's just a webinar in the series at this point. But we are talking all about peds rehab and specifically the combined programs. So I'm Ashlee Bolger. I am the PD for the Cincinnati program. I also coordinate this Road to Residency webinar series with the amazing Amy from AAP. So I am going to let my partners in crime introduce themselves, and I'm going to say we're going to go alphabetical by our first name because that's what came to my head.
Okay, I got that. Thank you. Thank you, Ashlee. This is awesome to see such a great turnout of people interested in different training tracks. I'm Dr. Amy Kanallakan, and I am the program director of the combined training program in Peds PM&R at University of Colorado.
Hi, everyone. I'm Eileen Shieh. I am the program director at the Jefferson / Nemours program in Wilmington, Delaware, and the Philly area. I am a Jeff lifer, and so if you have any questions about anything Jefferson, let me know.
Hi, everyone. My name is Kivlehan. I am the program director for the combined program at Shirley Ryan and Lurie, which is also like Northwestern, under the Northwestern umbrella.
Awesome. So, for those of you who might be new to the webinar series, this is pretty informal. I've got some pre-prepared questions that I get asked a lot from people interested in the combined program. I'll sort of serve as moderator, but please use the chat. Like if you guys have specific things, like I'll be looking at that too, and I'll pull some of those in, and we can certainly answer questions within the chat as well. So, this is really meant to be helpful for you all, regardless of where you're at in your journey in peds rehab and rehab. So just don't hesitate to ask any questions. So I am going to ask the first question of, and I think it's really general, but I think it sets the stage for a lot of things. Why do you guys think students should consider the combined method of training? Like what makes it unique? Like how do you answer that questions when you get that from a student?
I can kick us off. Um, so usually I say that the combined program is really for people who feel like they may have a little bit of being a pediatrician at heart, as well as being a physiatrist. And I think being able to go through all of the kind of typical general pediatrics rotations also gives combined residents a very strong foundation in normal development and the spectrum of normal development, which is super helpful as a pediatric physiatrist later on. So I think that's one of the unique things is you have the time to be able to kind of learn all of that information over a 5-year period.
I can go next. I'm a little bit of in a unique position to answer this question compared to the other ones because I am not combined trained. So there's a few different pathways, and none of them are wrong. But there certainly are times I think when you graduate residency and fellowship, you want to feel prepared for anything that's going to walk in your door. And I think being a little more comfortable with a lot of the pediatric issues, rehab is getting more and more medically complex because medicine is getting more and more medically complex. So I think the more comfortable you can be with that from all of those rotations you were able to do as a peds resident, I think can really serve you nicely in a career in peds rehab, especially on the inpatient side where you're really, really in it with those medical complexities.
Yeah, and just to recapitulate what people said, it's like a certainty that you want to do pediatric rehab. So I think as a medical student, pursuing that question first on rotations, whether it's who you get to work with at your local institution or finding sort of peds rehab adjacent specialties like child neurology or developmental peds, doing away rotations if you have an opportunity to. And then also being like, and I do want to work in the NICU and I do want to be in the ED and I want those experiences because I'm also a fellowship program director. And so I see the beauty sort of in complementary way that everyone is prepared for the same career at the end and everyone just gets there a little bit different pathway. And so I want everyone to kind of keep their options open. There's no wrong way. There's no one way of training that's kind of better or more prepared than another. I think it's about keeping both options open and really being open to both tracks. And then right now we'll be talking about kind of two, maybe a third track, like if someone does pediatrics followed by PM&R. But I think if someone's like, no, I really, really want to work some more nights and be on HEMONC and, you know, all of that. Like, I think if someone's drive within their training track is to have some of that pediatric acuity, then this combined track is great.
Yeah, the only thing I would add to that was just something I kind of thought through when I was making that decision. And we'll talk about this later, but I applied to all sorts of programs and different pathways and like made the decision sort of as I went along. But I think in the end, I just truly loved kids. And I think part of the draw for me was not having to go 3 straight years with hardly seeing a child. And that was a big one to be able to be like, yes, I get a whole intern year that's kids. And then like, I'm never more than like 5 or 6, blocks away from a child. And I just knew, I think that was going to make me happy. And, it didn't matter to me that that was in the PICU or the NICU, or I agree, HEMONC is a really rough rotation for us too, like, or the HEMONC floor. Like, it didn't like that made me more happy than having to live in adult world for a few straight years, so to say. So that was another thing that I just kind of felt when I was making that decision. So, what do you guys think makes somebody suitable, or some like qualities that you're looking for in, students that are looking at the combined program?
I think as we all have collaborated in discussing this previously, I think one thing that an applicant might think about is like, who's reviewing my applications? And so sort of with all clarity here, like a pediatric physiatrist who's combined trained. Also, there might be pediatricians, there might be your PM&R programs. And so I think the applicant who sort of catches the eye of the whole program, but also then complements like, when PEDS is reviewing it. So someone who's maybe done some PEDS rehab, so they really know that this is what they want to do. But then also your general PEDS rotations are important. And then you are doing anywhere from 18 to 24 months of adult PM&R. And so you better try it out. Make sure it's what you want it to be. So that can look like adult neuro rehab, some sports med, possibly MSK, if you need to find someone who's sort of with that experience. And so it doesn't have to be one of each of those, but I think those rotations and even letters that sort of reflect those experiences can be really helpful. And so I think some type of clinical experience reflecting the preparation of someone really pursuing a combined program in pediatric rehab, in pediatrics and PM&R, like someone wouldn't apply to ENT without doing an ENT rotation, so I think that's also where looking at this specialty and preparing someone really broadly is important.
I would also add to that that adaptability is really important for our combined residents. You're jumping in between 3 different worlds, from Gen Peds to adult rehab to Peds rehab rotations. And so, sometimes you're going from the NICU, then your next rotation is going to be adult stroke. And so you need to be okay with knowing that those changes are going to happen, and that you might have to refresh yourself on adult medicine and adult physiatry. And I think, a good way to reflect that in your application is, just like Amy said, to experience all of those worlds and make sure that you feel comfortable and confident with doing that.
Yeah, I would completely echo that. I think, looking through applications, I really like to see that you've really seen both of those worlds and experienced that, not just because I want to make sure that you're suitable, but I also want to make sure that you're going to be happy and that this is the right program for you, because it's squeezing a lot in 5 years. And so you're not going to love every day, but, I want to make sure that those really are the worlds that you want to dive into. And then I agree, really being someone who can hop back and forth, and especially for my program is very new. So I think, my current resident has just been so great with really being a trailblazer and helping form and helping give feedback and just being excited to be in that role. I think for some people who really like a lot of structure and clarity, that could be a frustrating role, which is fine. But I think that being that kind of person can be helpful too.
Yeah, I kind of look at a couple different things, or at least things that stand out to me. So like leadership and the ability to multitask, and that's like a weird way to phrase it, but I think it kind of echoes everybody else saying, you're really having to navigate multiple things at once. I am pretty open and honest, and when I talk to people, I usually say something to the effect of, this isn't the easiest way to get to be a peds physiatrist, and recognizing that, but then owning that and knowing that that's what you want, I think is super important. And so, just again, knowing what you're getting yourself into. And, I think helpful to talk to like some of our current residents. I think most of us will easily give you their emails, and like, they may not all have the same opinion, and that's okay too, but I think just being able to stand out in those capacities, I think can be super helpful. It's for me, it's really hard to review an application and not see a lot of, just kind of extra activities. And yes, you might have done well in medical school, but like there's so much packed into, like Emily said, like the 5-year program that like I want to know that you had some of that exposure and we're trying to do multiple things at once. So cool. I love it. We got some questions, so I'm going out of the chat. When it comes to peds rehab, what do career opportunities look like after you've graduated from one of these specialized programs? Do you have to be tied to a big academic hospital, or is there a possibility to work in private practice?
I'm sure everybody else can answer this a little bit better, but I I think obviously you're doing a lot of academics and teaching, so there's of course always going to be anytime you do something super subspecialized, most of the heart of it is going to be at these big academic centers because that's who hires you. But I also met a lot of people on the trail last year who had a really interesting perspective and wanted to actually do more rural medicine as a peds physiatrist and felt like having this pediatric background would really help them kind of straddle that and be more prepared because they don't have all of the other subspecialists at their fingertips at a big academic center.
I think so many different clinical opportunities. So I think the big thing for peds PM&R and peds rehab fellows is, in my experience, most people are kind of considering very similar jobs. So pediatric rehab physicians are in a shortage nationally. And so a lot of the jobs out there are at academic medical centers or standalone children's hospitals or integrated children's hospitals that I'd say a lot are affiliated with, say, PM&R training programs, but not all. There are some people in private practice in our national group. And so in some ways, some of those practices are, I'd say, unique, but also really strong and an option, mostly because there's a huge shortage of peds rehab. So some of those people in private practice may have a different sort of slice of the pie if it's just them. Like I am a group of 15 physicians. And so we all kind of have different areas within peds rehab that we specialize in. If someone's in private practice, it might be that they're really interested in spasticity or pain or spasticity and, medical equipment evaluations. So I'd say more commonly, people are in sort of an anywhere from a team, like a smaller group, like 2 to 4, or a medium to large size group. And then I think my experience, there was a question just about like how do combined residents maybe have a different career? I think just there are some people who might practice, like we have one graduate of our combined program ahead of me. So in the early teens, maybe she graduated in 2010. She actually she works as a complex care pediatrician. And then she handles, guess what, like orthotics and equipment and that kind of thing in her practice, but she is like a complex care pediatrician at Children's Colorado.
Yeah, and just going off of that, some of our graduates have done similar things of having a hybrid role of being a general pediatrician for med complex kids and then also wearing their peds rehab hat in different roles as well. I think, coming out of the combined program, in terms of setting, really you can just do outpatient or just do inpatient or just do consults. I think in general, people who go into the combined residency tend to like a little bit of everything, which is why you choose this route. And so a lot of our graduates, when they leave, they say, I still want a mix of everything. So I'd say that's more the norm coming from our program, but it doesn't mean that, you can't just do a certain setting or just treat a certain population.
Yeah, I would say in Cincinnati, I would say for the most part, everybody's getting similar jobs. And I would say maybe like a different way to phrase it is like our fellows and our combined residents are interviewing for exactly the same jobs for the most part. In recent years, I haven't heard of anybody who like really distinguishes the two. Now, the exception to that would be if you wanted to do complex care pediatrics. Somebody who is PM&R and then fellowship trained does not have the skills to be a pediatrician. And so that would be a little different. But in general, my residents are interviewing for the same jobs as our fellows. I think we also have I'll just say unique group of the last, I don't know, 5, 6, 7 graduates, where they have decided that not only did they feel the need to do 2 residencies, but they also felt the need to do another fellowship that wasn't related to peds rehab, but they didn't want to stop. So I don't know what's going on, but that's been a thing in our program lately. So we've had people go into pain. So they did a pediatric pain fellowship. We've had now 2 sports medicine folks. So I've had my second one. I've got a few that are toying with a sports medicine fellowship in the wings, but that is not something you have to do. I don't know why we're on a train of doing that in my program. It's not something I promote, but I don't know. They just don't want to stop doing training programs. I'm not sure why, but yeah, lots of other options. So we have a little bit more. They're looking for even more unique jobs because they're trying to meld a couple different divisions when they leave us. But that's a little bit unique to them. So I think that piggybacks a little bit, and we've answered sort of, but I'm going to ask it in this way too, is given the small size and niche nature of the dual peds PM&R pathway, how do your graduates typically carve out roles for themselves after residency, especially where they're not structured for dual trained physicians? Have there been any common challenges in using both scopes of training, and anything you've seen that's worked well or been creative? I think we touched on a little bit of those, but I didn't know if anybody else had anything to add.
I think like one thing within our smaller group, within larger groups, is all of our programs have been established a really long time. And Emily's program is newer to the combo front, but with super strong peds that's very used to combined training tracks and super strong rehab as well. So I think I'm going to say this, like strong program director leadership nationally, I think has made all of our programs successful within the small N that we have. And also our experience like with our programs collaborating with peds and communicating about schedule adjustments or the plan for the year, PM&R. And then also like we all have like dedicated time where the peds rehab learners are all together learning. So you're not just like off in one program, rotating in an abyss and then going to the other. Like, and I find that it's our peds rehab group, my other combined residents, myself, even our fellows in our group, we kind of identify all as peds rehab learners who are like keeping tabs on, hey, how's HEMONC? How are things going? And so it's not just like someone's flipping back and forth and we don't know what's going on. It's a lot of communication among our various program partners.
Yeah, I'll flip off of that for this next question, but kind of, integrating, how do they integrate into their respective, parent programs, so to speak, or cohorts, and, develop relationships and feel like part of those two sides. I might get us started because I always looked at it. I did a combined program. I'm just like Eileen, I'm a Cincinnati transplant. I never left. So, but I was really worried about that going into training. And it was just different groups of friends. Instead of one group of friends, I had like three groups of friends in a city that I knew literally no one when I moved here. And so I didn't feel alone. It was just like, did you call your, one group of friends or did you call your other group of friends to hang out this weekend? And I think we all have that, to some degree, however we identify those different buckets. But I feel like it's not an issue in my program. I agree, Amy. I think our little group of peds rehab learners, it's just special. It's been fun to see like the fellows and the combined residents and the faculty kind of bond as we've tried to be more purposeful in doing things together and sort of integrating that part. I mean, they all have each other's back. The pictures they have from their ridiculous outings. I mean, one of them organized peds rehab karaoke a couple weeks ago. I was not able to attend, but I heard it was wonderful. And like just a lot of other things that I feel like they've just kind of developed that, and it's a good, if they understand what each other are going through and what the challenges are. So
Yeah, I had a similar experience. I moved to Philly and didn't know anybody and was very, very regretful of my move initially. But then you meet your group of friends, I think what helps not all of the programs are structured the same way, but I think, intern year, everybody is doing a PEDS intern year. So all of the residents are starting together. And so there really is no difference between you and a categorical PEDS resident. And then our program, our adult rehab residents are advanced residents. So they're starting PGY2 fresh as well. And they're coming, from totally different intern years. And so when our residents integrate as a PGY2, they're coming in just at the same time that everybody else is. So you're just meeting a new group of friends at that point too.
Yeah, I agree. I think we probably all have our PGY2s really start. We do have a few advanced in our program, but they're really on the internal medicine side. So then, all 12 of them, now 13, get together their PGY2 year. So you're starting with your PGY1 class, and then you're starting with your PM&R PGY2 class. And I think those first few months of bonding are really intense, and that's when you're doing a lot of that socializing. So I think that is a big part as well, that you really are starting off with both of them because of the way that the timing works with how PM&R residency starts.
And this is us just copying what our trainees tell us and would be here to tell you guys. So I think that's this is not just our impression, but it's like you get actually more people. You learn, you get even like more like connections within the hospital, within your system. So
yeah, one of my favorite stories to tell, and they all know that I tell this story because I posted on social media when they tagged me. So that was, their fault for doing that. But it was probably 2, maybe 3 years ago at this point. It was when the like Backstreet Boys were doing their like national tour, and like so I'm old, and so like I knew the Backstreet Boys when I was in high school, but these people had like the second round of it, like they got popular again. And so like they all knew it, but we had the most eclectic group that went to the concert. They made matching t-shirts, mind you, mind you. It was like a mix of our fellows, our residents. We had a few faculty in there. We had some people like our care manager on the inpatient unit went with them. Like, and they had a grand old time. So just like I think it's just the personalities that you have, and those change over time regardless of what residency you're at or what specialty you're in. But like I do think there's something special about peds rehab folks. I don't know, I feel like we're all just kind of very well-meaning and enjoy each other's company, and it's really hard to make one of us angry. Let's see. Okay. I was wondering what programming experiences or supports your programs have that prepare graduating residents to be leaders in their fields and have the confidence to practice in hospital systems where they may be the only rehab doc or peds rehab doc. Sorry. Any thoughts?
Yeah, I mean, I think the big goal is to prepare people for that, even though we're training people in a system with like a plethora. I think in Colorado in particular, um, and a lot of our sites serve rural areas. And so our fellows in our fellowship actually have opportunities to do outreach clinics a few hours away. One is a plane flight away. And so if a combined resident was particularly rural inclined, I would then look to tailor our program to add more of those experiences in there. And then I think the other piece that's a lot of our programs have are some various training tracks, whether it's leadership development, the opportunity to be chief residents. I know Shirley ran AbilityLab in Colorado, and you guys can speak to this, but there's even some like educator, like how to learn to be an educator over at our system. It's like a 3-week elective. So like, how do you learn some of that like academic educational leadership and curriculum development? So I think some of those are just things that are like, how do you be prepared to be practicing independently? And then our whole goal is to be able to practice independently. So this is a 5-year program. Like people will be prepared to be pediatric rehab physicians in whichever community they're aiming for. And then a big piece of this is mentorship and development. If someone says, I want to be the only pediatric physiatrist in Wyoming, I would say, let's get on that. Let's prepare for that. And there's such a need. So if someone is really looking at an underserved area, I think some of the mentorship and the way that a 5-year program has some flexibility within it to like tailor it towards rotations that really prepare someone for that would be where my answer would be.
Yeah, I would say all big academic centers, not only, and as you look for any program, the program's going to tell you all these, great things about themselves, but also the actual institution has so many things for their trainees as a whole. And I'm sure that goes for all of our institutions. So their specific program often will have leadership or medical education advocacy tracks, but then the institution often does as well. And so I think being a big academic centers really affords you all of those institutional resources and training. I think in PEDS, PM&R, and PM&R, no matter where you are going to find people who haven't, or a nurse who's like, you're with who that you're consulting, what? So I think you kind of end up learning how to explain what you do and advocate for yourself. And I think in general, all of our programs are always growing and building. I think, even the ones that are so well established, because our field is having a shortage and other people are realizing what we're doing. So I think getting to experience those, joining new multidisciplinary clinics that are being formed, I think can be really helpful too.
Okay. I'm going to rip off the Band-Aid of one of my favorite topics, the standardized letter of evaluation. My buddies know that this has been a passion project for the last 2 years for me and a group of people. But so for those of you who may not heard, PM&R as a specialty released a SLO or a standardized letter of evaluation similar to what other specialties have been doing for many years. It is being highly recommended as a AAP, who is our national academic affiliated organization, that every student applying to PM&R this cycle has at least one SLO from a PM&R physician. We did a whole SLO webinar. It's recorded. Amy did great. Go listen to it. But like in general, we can't mandate anything. We have no power. I have no ability to create laws. But we're highly recommending it if you're applying. We as a group of 4, I think we all kind of talked about the SLO when it was in its infancy and not official yet. But we didn't really make a blanket statement for all of us. In general, it's been left up to each individual program if they want to mandate it or they want to require it or however they want to do things. I would say for our program in Cincinnati, I would highly recommend having one SLO from a PM&R physician I don't care if it's PM&R or Peds PM&R, do whatever you need to do. But I think, again, I'm in a unique position too, that I was heavily involved with it and it's a passion project. So I'm a little bit maybe more partial and fond of it than others on this call. But I would just say it doesn't matter to me who it is that completes it. But I would highly recommend, if you're going to apply to Cincy this year, doing it. Maybe in the future we'll have different recommendations from the group of us, but
Yeah.
I don't know if you guys had any other thoughts.
I would say the same thing. I wrote a letter for somebody who's applying, and I was like, I think I should do a slow for you. And I asked them if that was okay and explained what it was, because really more so because we need the PEDS PD and the PM&R PD to agree with our rank list. So I don't want them to have a hard time comparing you to all of the hundreds of PM&R applicants that they're looking at. So I think it will help you be on a level playing field, even though we're not particularly, I think, requiring it as a whole. I think it's a good idea. And I agree. I think from anyone, but I think just so you have one, just so you're, on base with everybody else who's probably applying to the PM&R side.
Yes, same. We're not mandating it. It would be nice to see, but we do understand that this is relatively new. And if you have found the field a little bit later and don't have time to get those rotations in, we definitely don't want to require it quite yet.
I'll just be a part of this whole same thing. I'd agree. I think because there's some people who only applied to the combined program. So if you do and PM&R is like, well, where's their slow? Like, we also want to be able to make sure we advocate for our combined residents, like in the whole cohort of people applying. That brings me back to my online thing that I took care of at the beginning of July, that I think applicants, if you have a slow, awesome, I'll encourage it as well.
Cool. Okay, could each of us share one unique aspect of your program that you're particularly proud of? Mine was the matching Backstreet Boys shirts. I'm taking that as mine. I'm just kidding. I'll answer for real once other people do, but
yeah, I mean, I think I'm super proud of the diversity of our patients, and both rural, urban, from a huge area of our country here in Colorado, and then also the people working at our institution serving people of all backgrounds. And I'll just leave it at that.
Yeah, I think at Jefferson, one of the things that I really appreciate about our combined program is that our residents get exposed to rehab in different settings. So they're exposed to rehab kind of in the private practice model, but also in an academic model. But they're also exposed to inpatient rehab as a standalone unit or standalone hospital, and then also as an in-unit hospital system. So you kind of get a little bit of a feel of everything and then decide kind of what you want to do in the future based on those experiences.
Yeah, it's a hard question because I think we don't know what's unique about each other. I think we all overlap a lot. We're all really great. I think, one thing our core PM&R residency really values is trying to give a lot of elective time so that each resident's residency can be a little bit different than the other person's, to really tailor exactly what they want. And obviously, is a little bit less flexible and a little bit more tight with all of the requirements that you guys have to hit in 5 years. But I think that idea is still really valued, of trying to make the residency something that works for you and giving you those opportunities, whether that is spending time with a radiologist or spending more time in the OR doing procedures, and really helping you tailor the elective time that you do have to your career.
mine is very similar to Emily's. As I was listening to her, I was like, oh, it's not exactly, but it's very similar. So not necessarily like elective rotations, but I think something that I've really been proud of and have been very purposeful in developing as I sort of took over the program a handful of years ago, is just allowing the residents to follow their passions and like making sure that our program supports that, whether that be me trying to find connections to people in the medical center, or trying to be creative in how we navigate the rules and different things that we have to abide by. But it's been really, really fun. I mean, most of the people that come into combined programs are pretty darn motivated, as you might imagine. They're choosing to do 2 residencies and take essentially 3 boards within like a 3-year time span once they graduate. And so, but like, it's not always within peds rehab. So in the last couple years, I've had people develop adaptive sports programs. I've got somebody who was really into adaptive video gaming, and developed a whole program in Cincinnati, moved to Indy, and now has a nonprofit that has 2 locations. And that's like his like love in life. And just some really, really cool things, like versions of that across the last, 5 or so years. And so I think that's something I'm just really proud of. It's not necessarily I'm doing the work for them, but like, I love that we can be creative and figure out ways that they can follow those passions. So, okay. Are there any interdisciplinary rotations or joint clinics where pediatrics and PM&R skills are integrated simultaneously rather than sequentially? For example, doing PED/TMONC outpatient follow-up combined with cancer rehab.
That would be really cool. But I think harder to design than it sounds. I think even in like a huge academic institution, I think there are these patients and families that you get to know. So I think no matter what, you end up seeing that longitudinal care, whether they're your continuity clinic patient or not. And so I think that that's something that's helpful. I think that there's times that you will be on doing Lurie rotations or the peds rotations, and then when you're doing your PM&R rotation in the later years, when you're really doing peds PM&R, you might see them after. So I think that there's some opportunities, but I don't know if you guys have any opportunities tailored specifically like that.
Well, and I think as you guys move beyond medical school, it's really taking initiative with some of that. So like we have our trainees who've sort of self-selected to follow a patient that they saw an inpatient who might be in the brain injury clinic for follow-up, or a kid who had a selected dorsal rhizotomy who's having a follow-up in gait lab and then is going to go back to clinic. And so that learner like gave me like for sort of their peds rehab block, some clinics they wanted to be in because they were following some patients who were going to follow up there, and I just scheduled it. Like it was easy peasy. So, and I think that's the true for all of us. So I think some of that, like the longitudinal care, that continuity that sort of flows through a system, can be pursued, and I encourage it. And it's really great when it's learner driven.
Yeah, I think on paper, it's a little bit hard to do full rotations that are interdisciplinary because there are so many ACGME guidelines that we need to work around and board requirements for both the Gen Ped side and the adult PM&R side. But I will say in all of our programs, you have the benefit of being 1 or 2 in your whole class, right? So you really can build your own program by talking with any of us. One of the things that our residents do is, we had one resident who was particularly interested in sports medicine, and so he would kind of pull those patients to his continuity clinic, or another one who's interested in onc rehab. And so on other rotations where they would be following up with rehab anyway, they would then recruit those patients to their patient panel.
Yeah, I think we do a lot of the similar things that people have already mentioned. And I think, and then the non-purposeful ones that I would just mention happen more frequently than you think they're ever going to. But the families that are, not strangers to the hospital, where like my residents will be like, so I met you when you were admitted to hospital medicine, but now I'm a rehab doc. And they've seen them like in the ICU, they've seen them on HM, they've seen them, now they're on inpatient rehab, and like the families love it. They're real confused at first, but they really like, it's fun to see that like perspective, and they really trust those people a lot. So they're like, oh my gosh, they've seen me from the beginning, and like I've known them for years, even if it's in a different capacity. So I think that's also another unique thing that happens more than I ever thought it would. So cool. I'm going to read it because I'm reading the answers right as I speak. If you match into an advanced adult PM&R program, can you still do a pediatric prelim year? Is that program dependent? Amy had kind of given that, I mean, I think technically if you're an advanced program, you can. That was my backup plan back in the day. Um, I may not have thought about it fully when I was doing it. I think I went back to that, like, I can't live without seeing children concept. But I think there are things to think about if you choose to go that pathway, in terms of where you choose to do residency. I think in hindsight, it would have been really, really difficult, if I was going into a PM&R program that was like in-house call, took care of adult vents or very complex medical things. I think that would have been really hard because I would not have had that training. But if it's not a program that has, that level of medical complexity to their, inpatient rehab folks, then it probably is okay. I mean, that was my backup plan back in the day.
Yeah, like think of your internship choices if you're doing a PM&R residency as what will best prepare me to be a great doctor in PM&R. And so I think the strongest PM&R residents are those who challenge themselves, who also chose to challenge themselves like in internship. So like look for a program that does manage acute patients. I personally think like some like even a transitional year possibly that's like intensive enough to give you some complex medical exposure, but allows you to do a couple peds months just to kind of keep your interest going could be a compliment. But I also know that like our fellowship track is a really great, that's where you're going to really get your whole preparation for peds rehab. So I'd say like don't go somewhere where people are boasting about how they didn't have to do much in internship. So like if you're applying, like find people who aren't burned out and are happy with the challenge, but also like feel like it's preparing them for residency.
For students exploring or early in exploring dual training, what kind of values or clinical moments tend to resonate with people who are really drawn to this field?
I mean, we get to enter a lot of people's stories during sometimes really hard times. That can be an unexpected injury of a child or an unexpected medical diagnosis that really changes where they're at functionally. And I think um, feeling drawn to being a part of partnership with that family in that moment, and some optimism, but also sitting in the discomfort of real counseling when things aren't great. And that's a learned skill. So that's not something you might hear and be like, that's me, but that's something you learn. And that's just one thought I have.
Yeah, I think it can be an emotionally intense field and an emotionally intense rotation. I always kind of talk to the residents about that when they're starting their peds rotation. And so I think there's a lot of high highs and low lows. I think you're really sitting with them through, days that are just the worst days of their lives. And then also, when they get to leave the hospital and seeing that joy, and sometimes seeing that joy when they thought that they could never have it again unless a certain goal was met. So I think sometimes when you talk about this field with other people, you get a lot of like, oh, you have to be a really special person to do that. And it used to really dishearten me when I was a medical student because I was like, am I making a mistake? But I think if you can really like see the beauty in those relationships, it can be really lovely. I think that the hardest thing about this job for me is kind of what I said before, that not everybody knows what you do. And it is kind of hard to explain what we do. And that is truly my least favorite part about this job because I don't like to market myself. But I think the relationships that you build in this field with families, I think are really, really strong. And I think that's probably all of our favorite parts of it.
Yeah, and I think another thing is, celebrating the little wins along the way, with kids who have had significant medical complexity or a new acute injury. it can be a pretty devastating and challenging time. But to be able to find the positive perspective and be able to celebrate along with that child and that family is also something that I really enjoy.
I love the continuity. So like I have a large outpatient practice, and so it is a lot of kids who are born with, say, what they walk in with. And so I've been able to follow kids, over the last decade beyond. And the family, when someone can pronounce my last name, great speech, but also like it's Kanallakan. I know. But and it just is awesome. So I think the continuity, it's not all tragedy. Some of it is just, families whose maybe birth stories were surprising, and walked a journey in that time and want us to celebrate their kid and be like, hey, what are they into? Okay, how do we best enjoy that? So I actually think creativity is like another piece. Creativity and positivity are things that really get us excited when we're kind of innovative with families.
Amy just took mine. I was going to say creativity as well. And I think some of that is what I have chosen to sort of niche specialize in. There's not a lot of evidence base for some of the things I do. And I'm often on Amazon and Googling like in the room because I'm trying to like piece together my medical knowledge and what I've seen on, maybe social media and like, how can I fit this together to work this kid? But like, that's like so much fun for me. Like I love that more than memorizing like I don't know, some protocol for some disease or, whatever. And I think the other things I tend to like think about, like when I think about like why I chose this as opposed to other things, like not that I don't care what your diagnosis is, but like that's not fulfilling to me to diagnose something. And so like, yes, we do some diagnosis and rehab. Like I'm not saying we don't, but like, as a whole, we're the step after diagnosis. Like we're the plan for the future, make them independent or make them as independent as they can, or figure out how to do X, Y, or Z in a world that's not set up for a wheelchair, like, and yeah, they have whatever diagnosis they have, but like, it wasn't fulfilling for me to get the genetic report and like be able to say, yes, I picked it, or, whatever it was. That just wasn't me. It wasn't where my heart was. So I think that was another big thing that I kind of realized as I went through rotations, that I saw as a difference maybe between other subspecialties within peds. So, okay. Well, I got 10 minutes. Okay, perfect. I got more questions. Wondering if there are any specific advocacy efforts your residents have worked on since peds rehab allows for such a specific expertise in the community.
I mean, I think advocacy is a requirement within all PEDS programs. So you will see sort of everyone will be like, oh, we all do advocacy, and everyone does it. We have to. In particular, some of our PEDS residents have gone to Capitol Hill here in Colorado, done advocacy for Medicaid for undocumented children. So Colorado passed a law a year ago that takes care of medical care for even children with disabilities of undocumented parents. Which has been wonderful. And then also another one of our most recent graduates who's now on faculty is actually doing a lot of sexual health and disability education, which is advocacy as well, just because it's disability, sexual health is needs to be talked about.
Mm-hmm. And say, as I mentioned previously, we've had a cohort of sports med gurus, so we've got a lot of adaptive sports, like various things in the advocacy realm for that, and adaptive activities. So we have a lot of like people that are really enmeshed within our organizations in town and fundraising and various avenues for that. So I think that's been what comes to mind over the last 5 years, just based on who I have in my program right now and who's graduated. So
Same, adaptive source has been a big theme in ours too.
cool. And then Amy, thank you for providing the link for the slow. Appreciate it. And then we've got, let's see, how would a combined residency prepare someone interested in working in adolescent transitional care compared to the other residency pathways? That's a great question. Just think.
Think you get all of the acute experience of knowing where that kid is coming from. So if you have a young adult who has CP who potentially had head cooling or body cooling in the NICU, you know what that looks like and kind of how that translates. And so I think having that background medical knowledge then helps to inform what that family has gone through and also kind of prognosis wise too for other diagnoses and other interventions.
Yeah, I think you also know where they're going because of your adult PM&R experience. So, you might see adult patients with CP who have pain or, are struggling to stay active in the community once school is over. So I think that you really get to see all sides of that lifespan. So I think it's a great way to get into transitional care.
And someone could just do PM&R and be interested in this. So I think transition of care is like such a huge need that I think combo program prepares people well because you kind of know what congenital heart issues are, or et cetera. But you also can learn in other ways. So I think this is where it's great if someone does a PM&R residency and then a fellowship and wants to do transition, but the secret's out there, like you can still do it even just with a PM&R residency. But that I think just finding people who are passionate of the journey of kids into adulthood and still needing neuro rehab care is so important.
Yeah, I think the other thing I would just add a different perspective is it's often really hard for families to make that transition. If for those of you who may have experienced peds healthcare and adult healthcare, they are not equal. They are not similar. They function very, very differently. And so I think, going through a combined program, you get real life compare and contrast, how things are dealt with on both sides. And I think I don't do transition of care, but that could be a very unique perspective to have as you're trying to help families navigate that, I would imagine. So. How are there opportunities to work with underrepresented communities, patient populations in both residency as well as your attending roles? I think Amy sort of touched on a little bit of that, but anybody else have any other thoughts?
Yeah, we have some free MSK clinics at the resident staff. And then one of our peds rehab faculty is interested in global health. So took our peds rehab fellow to Belize this year and they did a project there and they were really able to, do a lot of great work there and hopefully that's something that will continue. So that was a really, really fun development for our program this year.
And I should just share the languages that I've had to access on our video language line. Everything from Arabic, yes, Spanish, French, Karen, Caringian. I just butchered that, but I think the refugee and immigrant population and also just people who speak multiple languages as their first language, are all over the United States. And so I think we want our children's hospitals to be places for people to come and feel safe and feel heard and be able to be communicated. So, I think all of our programs are in big major cities with diverse patient populations who see everyone, so some people are like, but I'm on Medicaid. I'm like, this is what we do, we'll have to transition with whatever changes have to happen. But anyway, we're here still to serve everyone.
See, we have we're a destination program for a lot of the Arabic countries. I don't know if anybody else's hospitals do this, but we have a very, very large population that come to get care from the Middle East. So I think that's been an interesting thing to learn, to navigate because that's very, very culturally different, and just how to navigate that within our US healthcare system. But that's a big, I feel like, population that we have in Cincinnati.
At Jefferson, our residents rotate through a refugee clinic as part of their outpatient experience. And then we also have a pretty large Guatemalan population that is undocumented that speaks the dialect of Spanish that has been really cool to be able to treat them.
What is the most appreciated benefit that is offered to the residents at your program? Oh, I know what this is for
Free
me.
food.
That's ours too. They all. So I don't know,
100%.
Eileen, is yours on the peds side? Because our peds residents get daily lunch provided for them. So it's
Yep.
part of their noon conference. There's food there and it's like decent food, but they love it.
Yep. Yeah. So our peds residents, when they're on peds rotation, they get lunch. And then if there's a morning report that's longer than half an hour, they get breakfast too. And then on the adult side, they finally recruited. So for didactics, they get coffee and donuts from a pretty shishi place around here. And then they also have a stipend when they're on call.
I actually still remember my interview when I was a medical student at Nemours and the lunch being so good. Yeah, I remember it was like the best lunch. It hasn't been lost on me in over 10 years. Um, I think that on our peds side, I'm pretty sure that they get noon conference lunch. On the PM&R side, you get it like about once a week on Thursdays when we have our journal club or complex care series. But only once a week on the PM&R side, as far as I know. Um, yeah, I don't know the most appreciated benefit. It's so hard. I mean, I think that we are a big program. We're a big PM&R program. So I think it really, I don't know if it's a benefit, but I think especially as residents go through, the network is really wonderful because it's just a beast of a program. So you can usually find somebody only a few degrees away from someone else. And so I think that that can be a really nice resource for us.
And I think I'm interpreting this as like benefits, like, but I think in Colorado, I just had lunch with our incoming fellows and they were really happy with their salaries, so I think our House Staff Association has advocated well. I have not done a comparison or anything across programs at this point, but someone really appreciated that. And then also having been a resident who had a baby in residence in my own residency here in Colorado, and our healthcare that I have is the same as what our residents have. It is very affordable for a family to have health insurance as a resident. So I think that that's important because life hits and people have cancer and get sick and stuff happens. And so it's really helpful to also, like, for me, be proud of, like, yeah, that's where I go for all of my healthcare. I don't have to, but I choose to because University of Colorado has great subspecialists. So that's something I've appreciated myself and my trainees told me.
And we're hitting 9 o'clock, but there's one more question we haven't answered in the chat. So I'm going to ask it and then I'll kind of start wrapping us up. But any resources that your specific programs have for kiddos and families transitioning to adult medicine, any established transition clinics?
Yes, research, established pathways, clinics, experiences in those at Colorado.
Yeah, I feel like you guys are doing a lot of like research in that area.
And it was a huge gap. Like, this was
Yeah.
not something to brag about 5 years ago. So I think it's
Yeah.
also like something where like we can, like, a newly hired faculty who is out of our combined program started really spearheading this and really grew it. So
Yeah. I think that we're just lucky that we happen to have a lot of good neuro rehab adult providers, and so it hasn't been too difficult for me to just transition. We do have some other supports for kids, though. We have like a what we call a transitions camp, which is cute, where they learn how to, like, we have one for people who have some intellectual impairment and then one for without, so they can kind of work on different things with financial management and cooking and figuring out public assistance. So that's kind of a fun program to help our kids go through that, and then they can do like fake medical interviews with adult providers to help them really lead their own healthcare. But otherwise, we really just kind of transition them when we feel like we're ready.
We have a designated transition team that includes a med complex pediatrician and then also a social worker who first meet the family when they're 16, when the child is 16, and then they follow them annually, kind of working on those milestones of, all right, now you're 18, what can you do to help prepare yourself for appointments, and then really for that transition at 21.
Yeah, and I would say we're probably maybe a little newer to the transition game. I think for a lot of years we did not transition our people. So, which I think it's not uncommon in peds rehab and probably still even places today. But we've gotten really lucky in the last couple of years and had one of our former residents go away for peds rehab fellowship. But her whole goal all along was I'm developing a transition program for all these kids that we've never had anything for. And so she came back to Cincinnati after fellowship. But she's been working pretty hard. There's a new center in Cincinnati that's tailored towards all disabilities. So I think it started in like the developmental disability cognitive realm, but like it's really kind of broadened. And so I think we are definitely in the grander scheme of things in our infancy, but it's been nice to see that we have some options now. So that's been fun. But
It's hard. It's harder than it sounds. When I was a resident, I would see like a 26-year-old and kind of, why would I see a 26-year-old? And now that I know these kids, like it's like tears all around. It's horrible. You want to keep
it's
them
hard.
together.
Yeah, it's a different perspective for sure. I feel like I'm gonna have waterworks when I have a few of my kids that I've known since they were babies and I have to transition them. It's gonna be rough. But I get it. So. Okay, well, we are a few minutes after 9 o'clock and I want to be respectful of everybody's time. So, Amy, if you want to put up the QR code, I'll kind of do that little brief blurb. So, Amy and I have been working in the background for this road to residency just to get some feedback from you all in terms of like what you liked, what you didn't like, so that we can make evidence-based decisions for following years. And then certainly if you are interested in connecting with other medical students, there's a QR code for that through our online platform. And I'll leave those up there while I do my thank yous. But I just wanted to thank my co-PDs. I think, we have a great group of the four of us, and I think have really been a source of bouncing ideas off of each other and doing these sorts of things. So thank you guys for giving up a little bit of time on your Tuesday evening to join me. And then thanks again, Amy, for organizing all of this and reminding me that we were doing it and always keeping me on task. So greatly appreciate it. But we're throwing emails in the chat. So I know I'll speak for all of us, but I think any of us are more than happy. Sorry, I'm typing while talking here. To field questions, just shoot us an email. We have no problems giving advice and talking through specific things that you may not have had time to talk through today. So don't hesitate to reach out, and hopefully we'll see you all around in the future. So bye, everybody.
Thanks, everyone.